I get confused. I'm old.
We didn't get that recorded, Barry, which is great. Okay, I think we could start with introductions. Good morning, everyone, and welcome to Department of Medicine Grand Rounds. We're very exciting topic with very exciting time today. You know, it's 23 days till June 4th, and I was sharing with our panelists earlier that it is my last time on inpatient clinical service without the 20th century medical record system. So next time I'm on service, I'll have Epic to help me. We have a wonderful 3 speakers today to help us understand how we're going to thrive in Epic world. What do we need to know? It's very important things that are going to be very practical and helping us following June 4th. Dr. Barry Lam, I don't think anyone who doesn't know Barry right now, even if you didn't know Barry as a physician-in-chief and a gastroenterologist and an old-time McMaster physician and full-time professor, you know Barry right now as the executive physician sponsor for ODYSSEY, who's after every physician to learn about everything needed about ODYSSEY and taking all what we need from ODYSSEY and Epic and implementing it for us so we can make the smooth transition into the new hospital information system. Dr. Amna Ahmed, one of our general internists, associate professor, and all-time quality improvement, patient safety person, leading that in GIM and residency training, as well as recently with the ODYSSEY project, took on the responsibility of the Associate Chief Medical Information Officer and doing a lot of work for us as the Department of Medicine, bringing our voice to the important discussions. And Dave Miller is a pharmacist and been in the HITS clinical informatics team since 2018, and now working closely with the Project ODYSSEY and member of the ODYSSEY team. So all these order sets that that we've put together coming into Epic has a focus on the things that we'll hear about today, which are very important in our practical life related to consults or consultant orders, provider teams, which is very exciting, and patient list. So without further ado, I will pass it on to Barry, and we'll take you through this journey towards thriving in Epic.
Good morning, everybody. Thanks for joining us. It's really my pleasure to do this presentation today. I hope it's going to help you get by some of your concerns. We know beyond the shadow of a doubt that that the Epic training is an introduction to how to navigate in system. But we also know beyond the shadow of a doubt that there are many items that aren't explicitly or as in detail enough presented in training to help you feel comfy when you first sign in after June 4th. So my hope today is to take advantage of my colleagues' knowledge to help you have some practical ideas about what this is going to look like. We'll always start with our land acknowledgement, and of course we're privileged to provide care on lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous people as keepers of our land. As Khaled said, it's 23 days to go live. My resting heart rate will go up about 3 beats per day as we get ready to make this transition. But I would also just real quick make a pitch for those of you who have McMaster admin assistants. I suspect many of you do. We're holding a town hall tomorrow at 10 o'clock for all the admin assistants to help them understand what their critical role is going to be as we move towards go live. And I would strongly encourage you to encourage your assistants to take advantage of that. We will record it, but if they can sign on, excuse me, I think it would be so much the better. So Dave is going to take over very shortly and is a wizard in the Epic world and navigation. He'll tell you a little bit more about that in a moment. That'll be followed by Amna, and then I'll jump in at the end. I will adjust the timing of what I go through so that we absolutely for sure finish with not less than 15 minutes for questions. So Dave will jump in shortly, but here's the items that he's going to cover. And this is about how you find your way around in the Epic world and what some of these terms mean. So Dave, I'm going to stop sharing and we'll let you jump into system and off you go. Thank you.
Great. Thanks very much, Barry. Good morning, everybody. Pleasure to be here with you. And just confirming at the moment that you are hopefully looking at my Epic login screen.
Yep, all good, Dave.
Okay, terrific. So the first thing I want to just touch on quickly are aspects of the importance of logging into a specific department when you're accessing the system. So I've entered my username and password, and I'm clicking the login button, and I'm presented with a department to sign into. And the system will remember the last department that you'd signed into. And hitting the magnifying glass, you can also see you can expand that for a list of departments you've recently logged into, or you can search for a much broader list of available departments. So the question is often, what's the importance of signing into a department depending on the space that you're working in, be it ambulatory or inpatient? So one of the reasons that signing into the department has very important relevance for you is because the department that you're signing into contains a number of the settings that you see when you access your workspace. So there are a number of different things in Epic that govern what you see and what you can do. Things like security settings, profiles, the departments that you sign into. But signing into a particular department tends to govern a number of the important settings that you'll see, and particularly in the ambulatory space. So a straightforward example of this might be that an ordering preference list. So we could expect that the labs and medications that an adult surgical department might order would be quite different from a pediatric endocrinology department. And many of those types of preferences are governed by the department that you sign into. So when you're working in the ambulatory space, it's really important that you stay signed into your particular ambulatory clinic to make sure that you're seeing all the settings and options and choices that you might expect to see. If you're moving between clinics, the other thing that's available to you through your Epic button is the ability to change your context. And change context simply allows you to jump to a different department without having to log out and back in again. So by clicking change context, I can quickly select a different department and then move into my workspace, and I should see, again, preferences and choices that are appropriate to the department that I'm in. In the inpatient space, if you're working exclusively in the inpatient space, we have what are called virtual departments. The virtual departments tend to have fewer settings associated with them because for our inpatient units, we tend to have attached more of the workspace settings and preferences at more of a global level, where in the individual ambulatory clinics, there are much more nuanced differences for some of those areas. So signing into the inpatient space, you would use one of our virtual departments. So for example, I might sign into HHS virtual general internal medicine or general surgery. And again, these virtual departments house settings, but you're not really signing into the physical department the same way that the nursing staff will when they're logging into the specific unit that they're covering. If you're working between the ambulatory space and the inpatient space, the good news is that you can sign into your ambulatory context. So for example, I'm signed into HGH ambulatory urology at the moment. And even though I'm logged into my ambulatory department, I can move into the patient list activity and some of the other inpatient workflows, and it's quite seamless. So even though I'm logged into an ambulatory clinic, once I've sort of moved onto the inpatient side of the house, I'm going to see navigators, selections, and choices that I would have expected to see even if I'd signed into one of those sort of virtual departments that are intended for strict inpatient use. So in summary, working in the ambulatory space, sign into the specific ambulatory clinic. If you're working exclusively in the inpatient space, you sign into one of those virtual departments. Again, virtual general internal medicine, virtual infectious disease, virtual surgery, that house the settings that would be important for you in the inpatient space. But by and large, if you're moving between those environments, you can primarily sign into your ambulatory department, jump over into your inpatient workspace, and the experience for you should be generally quite seamless. Just a tip, if you're ever looking for things like note templates or ordering preference lists and you're not seeing what you would expect to, one of the first things to just double check is the department that you're logged into. The other thing just to touch on really quickly is your in-basket. Your in-basket is a space where you can manage communications that will come to you from both ambulatory and inpatient encounters that you've been working with. So you can work, again, signed into your ambulatory context, you can work through your in-basket, and you'll be able to manage activities for both the inpatient and outpatient encounters. I do recommend you stay logged into the ambulatory setting because you may find, depending on the type of activity or task that you're executing through in-basket, you're going to be jumping in and out of ambulatory encounters where you might want to ensure that you're seeing the expected options and choices. So staying signed into your ambulatory clinic is the way to go. And I hope that makes sense. Okay, I'm going to change gears now. The other topic I wanted to touch on that we were asked about was pended orders. So I'm going to completely change gears now. And I'm going to show you quickly. So the concept here would be if you're a consulting provider, for example, and you're writing suggest orders, what does that look like in the system? So I'm signed in a different provider role. I'm just going to slide my screen over. And I'm signed in as a resident, and I'm in a patient chart, and I'm going to, via my ordering sidebar, place an order for a patient. And I'm just going to pick Ramipril, and I'll just bypass some of these advisories that we're seeing here that are a function of our test system. And I'm going to order my patient Ramipril 5 milligrams daily. So normally, if you were going to put this order into action, you would sign it. Instead, though, you have an option to save work. So if I'm writing suggest orders, I can save this work. So this essentially pens the order, where then an alternate provider can see that work and make some decisions about it. So I'm going to click Save Work. And when you do that, you're given an option of whether or not you want others to view the work that you've queued up. So if you're kind of working on the orders and still thinking about them and they're not ready for others to see yet, you could say not ready. And those pended orders will be visible only to you until such time as you're ready for others to see them. If you are ready for others to see them, you can click Ready. You can even add an additional message to those orders for context for the person that's viewing your saved work, and then simply click Saved Work. Depending on the situation, the urgency, you might want to use, it might require a phone call to a colleague to let them know that you've queued up those orders and they need to be looked at urgently, or alternatively, you might consider using secure chat as an option for messaging your colleague about those orders. So you've got different options for communicating, but if it's urgent, in addition to pending the order, likely some direct communication would be wise. There are notifications and queues in system to let you know that your patient has pended orders, but again, if it's an urgent situation, that extra step of communication might be important. I'm going to switch over now to the alternate provider, and I'll jump into the chart and show you what that saved work looks like as a different provider. So I'm going to navigate to my patient. And when I access the orders activity of that patient chart, I can see saved work here, and indicates that it'll tell you who signed the work, when it was pended, the date and time. I can select that and delete the unsigned work if I don't want to execute those orders, or I can click Manage this unsigned work. And in doing so, the order becomes active and I can sign it as is, or I can modify or make any other changes. So that's how we would envision suggest orders to work in the Epic space. You would do save work rather than sign the orders. Communication as appropriate to the alternate provider who needs to see those orders. Then the second provider can come in and manage that work. So that is appended orders. I wanted to spend the balance of the time talking about sort of managing patient lists, and this ties into what's called the treatment team, your patient assignments, and provider teams. We get lots of questions about those, and really at the when you're live in system, one of the things providers really want to know is the list I'm looking at of my patients to round on. How do I know I've got the right patients? Have I got the right list? So I'm going to jump back to the patient list activity. And the patients that you see on your patient list are determined by your participation, if you will, in the patient's treatment team. So I'm going to open the patient chart, and we're going to just quickly explore who's on the patient's treatment team currently. So I'm in the patient chart, and from the storyboard, I can access the patient's treatment team, and this will list different folks that are involved in the patient's care. It will list the attending and admitting providers, and it will also list any provider teams that are involved in the patient's care as well. So you can see at the moment that we've got a provider team here attached to the patient. The membership on that treatment team does two things. It first allows people to look at the patient chart and understand who's involved in the patient's care, but then the second important thing that it does is it drives your patient's list. So when I'm looking at my patient's list, and actually I think I'll switch over to a cleaner view here, just because in the test system we all do a lot of manipulation of the various patient lists. So I'm here as my resident looking at my patient list. And your patient list will be a combination of patients for whom you're somehow attached to the patient through the treatment team. Again, you might be the attending, you might be the admitting provider, you might be consulting on the patient, or alternatively, you're a member of a provider team that's currently looking after that patient. So to add patients to your list, you assign yourself to the patient, and you can do that manually, or you can do so by signing into your provider team. And similarly, we can add patients to our treatment team manually as well. I'm first going to go down to this list of provider teams that I've got for the Juravinsky Hospital, and I'm going to bring that provider team list up to a folder that you'll have available to you called My Provider Team's Patients. And via that list, I can see all of the patients being looked after by a particular team. I want to give you the example where I'm perhaps covering a couple of different teams. So I'm going to bring those relevant team lists up to me. That's just for convenience. I can view them here at any time. But a question we're often asked is, if I'm covering for a particular team, how do I sort of consolidate all those patients, maybe from one or multiple teams, into my own personal rounding list? And that's what I want to show you now. So at the moment, as the resident, I don't have any patients on my list. When I first log in, I'm presented with something called the sign-in tool. I'm going to go back to that now. And you'll see the sign-in tool pop up when you're logging into an inpatient department. And the system will remember teams that you've interacted with recently. You can accept the team that's presented to you. You can remove those and pick entirely different teams. So today, for this example, I'm going to sign myself into MD base team X at JH. And in addition, I'm covering MD base team F at JH, and we have some similar names, and so you have to make sure you're picking the right team as well as the suffix for the hospital. So I'm picking team F and team X for JH, and you'll note now that when I sign into both of those teams, I've dynamically added all of those patients to my patient list. I didn't have to go through and individually assign myself to all these different patients. Simply by signing into the team that's looking after those patients, I could dynamically add or remove those patients to my list. And as you can see, if I sign out, those patients will dynamically leave my list. So you might have some patients that you're sort of permanently attached to, again, by a role of attending or admitting or a consulting patient, that regardless of team activity you want to follow, and they'll remain on your patient list. But then for when you're covering different teams or switching among teams, you can use the sign-in tool to sign in and out and make those selections. And you also have the option of signing into teams without selecting any patient assignments. So perhaps you might want to be signed into a team for communication using things like secure chat with your other team members, but you don't want to actually appear on the treatment team for a particular patient. You can sign into teams with 0 assignments, but you must pick at least one team. So I can sign in, but as you'll see, because I didn't make any patient selections, I don't have any patients on my list. The other thing you can do when you're signed into system is you can click the signed in providers button, and it will show you other folks that are signed into the same team. So if there were other providers signed into the same team at the moment, I would see them listed here, and I could even use the secure chat feature right from this window to chat with individuals or with the team. The last thing I wanted to cover really quickly is just showing you how to reassign patients. So the assignment of the attending is something that can now really largely move to provider responsibility because of how easily it can be done in system. The access to making treatment team updates, it's available for providers, for nurses, for unit clerks, but we do view it primarily as a provider responsibility because it's those providers, the attendings, and the team members that know that team structure, that understand the team structure, and can ensure that those assignments are correct. So I wanted to show you just quickly how you would reassign the attending if perhaps you were rolling over the attending and you wanted to change this assignment. So I am going to go to my patient list, and I can multi-select several patients. I can hold down my control key and make non-sequential selections, or I can hold the shift key down and make multiple selections. And by simply right-clicking, I'm given a treatment team menu, similar functions to what I could have accomplished by jumping into the chart right into the treatment team activity, but I can simply take action on a number of these from here as well. So I'm going to say assign others, and I'm going to, I know Barry is taking over as the attending, so I'm going to put Barry's name in here. And you can assign providers in different treatment team roles, but in this case, Barry's going to be the attending, so I'm going to indicate that Barry's the attending. And in doing so, those patients will leave my patient list. They're now moved over to Barry's patient list. So the provider, the attending who's sort of signing off on the patients is the ideal person to multi-select the patients that they're handing over and assign the new attending. And you can even make that a future function as well. So you can say assign others, and if you wanted to, if it was appropriate, you could actually set a future date and time for that assignment to take effect. So if you knew Barry was starting tomorrow morning at 8 o'clock, that could do that as well. So a quick trip through the treatment teams and the impact on your patient lists. In summary, by attaching yourself to the treatment team, it not only shows others who's involved in the patient's care, but it drives your patient lists. And you can use the sign-in tool to leverage the patient and provider team coverage of that patient to dynamically add or remove patients from your personal rounding list. And I will stop there. Thank you.
Thanks, Dave. We'll kind of switch gears and talk a little bit about patient flow and the ADT navigator. And the reason why I wanted to include this in our rounds today is because this is going to be a bit of a big change for us compared to our current system. Next slide. Barry, are we able to put the presentation in presentation mode just to some of the demo screen? Perfect. So right now, the way we sort of do our charting and our patient flow is that each encounter exists completely separately. So if a patient is coming into clinic, they have a paper chart in clinic. If they're admitted to the hospital, there's a paper chart for that encounter. And if they're readmitted, it's a whole new chart all over again. And all of the charting and sort of the encounters occur separately. And because it's physical charts, there's no issues for us to sort of overlap. But in our new system, we are going to have multiple encounters all happening on the same patient existing within the same electronic medical system. And that's why it's very important to understand patient flow and the ADT navigator, which is admission, discharge, and transfer navigator, because a patient can now have multiple encounters. Some of the encounters may in fact be at the same time. So if a patient is admitted at Juravinski, but is going for a neurosurgery assessment, clinic assessment, that's happening at the same time, and two separate encounters have to exist now within the same system. And this is just sort of a visual diagram to sort of show, and it may not sequentially happen, it may happen at the same time. Next slide. So with regards to patient flow, it's important to sort of understand the ADT navigator, and that's the admission, discharge, and transfer navigator. And it's very important to sort of make sure that we have the right patient in the right encounter. And what sort of drives that is making sure that you're using the right ADT orders. Next slide. So just to sort of, and we went over this in our sort of go live readiness presentation as well, but I wanted to go over it again for everyone here on rounds. A lot of patient flow currently is not necessarily driven by physician orders. We write orders to discharge patients, to admit patients, but a lot of background work happens with patient transfers and bed management. But in the new system, because everything is interconnected and all of our facilities are using the same EMR, a lot of that stuff is going to be sort of triggered by physician orders. So for instance, right now, if I want to send a patient to the cath lab at Hamilton General, all I do is fill out a rec, and then a lot of background work happens to try and get a bed at the general, to try and arrange transport. But now, because everything needs to happen within the same system, my request to transfer the patient to Hamilton General is what will trigger all of those requests. So making sure that we understand sort of the admission, discharge, and transfer, as well as leave of absence orders, that's what's going to activate the placement of the patient into the right bed and the right unit. It's going to enable care to occur for those patients. So medications, diagnostic tests, their meals getting delivered, all has to occur within that order. So if a patient hasn't been placed in the right sort of a patient flow, all of those things will also get delayed. So this allows us to have that sort of timely flow of patient into, within, and outside of HHS. And it is sort of a Ministry of Health requirement to make sure that we're doing this right. Next slide, and I'll explain what I mean by that. So right now we have multiple sites, and yes, they're all part of Hamilton Health Sciences, and we all use the EMR, but the reality is that each admission, each transfer, whether it's in the same institution or between institutions, despite the fact that they're all HHS and they all use the same EMR, they do have to be treated as a separate encounter and as a separate institution, which is why even though it's the same EMR, if a patient is going from Juravinski inpatient to rehab, it's a separate encounter and a separate institution, and therefore there has to be a formal process to end their encounter, what's happening currently, and then start a new encounter at rehab. And just a reminder that we will now be doing medication reconciliation for all patient transitions that sort of require admission, not necessarily if a patient is just going for a clinic appointment. Next slide. So this would have been mentioned in most training sessions in terms of, okay, what does discharge readmit mean? What does transfer mean? If a patient is going from an HHS facility to another facility, that's a discharge. If a patient is going from Juravinski inpatient to rehab, that's a discharge and readmit. So when does transfer apply? When does discharge readmit apply? What is leave of absence? If for some reason, by the time go live comes around, or by the time you're doing service, you're not sure what those definitions were or when to use which part of the ADT navigator, when you go to the admission, discharge, transfer navigator, there will be a built-in guide that gives reminders of what those definitions are and which sort of order to use. Next slide. So the reality is that patient flow can be complex, and depending on what service you are on, and especially some of the inpatient services, it is very challenging to cover every single patient flow and the nuances of every single transfer within training. And to give you guys an example, the patient flow work group has met once a week, every week for almost 1 year to map out every single patient flow. So it's very challenging to cover all of that in training, which is why we wanted to sort of do additional training. There were patient flow days in, I believe it was in April or late March. I'm not sure how many physicians had a chance to go in. It was a drop-in session, but if you didn't get a chance to go in, there are additional tip sheets as well as training on our e-learning system. Next slide. So when you go to your e-learning system, and sorry, it looks like the link got cut off, but where you had done all of your e-learning and your modules, a lot of the other high impact workflows such as patient flow will be there. We haven't necessarily listed all the courses on your homepage because we want to make sure that we don't crowd everything. But if you are interested in learning more about patient flow and you think it will be relevant for your clinical practice, you can just search high impact workflow, HIWF, patient flow, and then you will get this patient flow video come on. Next slide. And then sort of the high yield patient flows that I think we are going to be relevant, that are going to be relevant for most people have been added. And these are videos with demos as well as explaining how you would do these orders. So if it's a direct admit, if you're doing a patient that's going from ED directly to diagnostic imaging or inpatient, transfers from the ICU to the ward, if you get a code STEMI either in ER or on the ward, and then a few additional demos have also been included. Next slide. So for instance, this is just a screenshot of the ICU to ward demo. And the demo is sort of very similar to what Dave did. It actually goes through all the orders and all the steps that you would need to do this transfer or sort of ensure the proper use of the patient flow. And there will also be sort of explanation in terms of why we are doing what we're doing, so you can fully understand the clinical workflow. Next slide. There's also a patient flow tip sheet that goes over some of the big differences between what we're doing currently as well as future, and just a few reminders on the definitions. Next slide. So this is just a screenshot of the patient flow. And so for instance, some of the differences in terminology. So right now, leave of absence, we think of usually as a day pass for a patient going outside, versus leave of absence in Epic can be essentially, it's a leave of absence from your current patient encounter. It may be a leave of absence to have a day pass. And I know it's more common in certain specialties compared to others. It's quite common in pediatrics, for instance. But leave of absence can also mean that you are leaving your current encounter to attend another appointment. So if a patient is, let's say, admitted at Hamilton General, but they need to go to West Fifth or for another outpatient appointment, that's a leave of absence for them. But their current encounter and their current admission doesn't change. Their bed is still open, but they're not necessarily being transferred. Next slide. Okay, I'm going to switch gears a little bit and talk about handover. Because I think this is going to be very relevant for pretty much all specialties within Department of Medicine. Right now, the way we do handover, most services and most of our subspecialties use the SharePoint handover list. And I'll go over sort of broad categories of how you can view handover within Epic, and depending on your personal or your subspecialties needs, you can decide sort of what fits best for you. So the big broad categories are, you can use the provider team or the patient list simply as it appears in Epic, and that will have the patient's name, their basic demographic, their admission diagnosis, who the MRP is. Sometimes the code status will come up, and you can change what shows up on your patient list. And very similar to what Dave demonstrated, you can either create your own patient list. So if you have a new consult service that doesn't have a built-in patient list, you can certainly say ID service at Jaravinsky, I'm going to create my own patient list. Or you can use pre-existed provider team list. Pretty much most of the services that we have right now, whether it's consult or inpatient, we do have built-in provider team list. And as long as a patient is assigned to that provider team list, or you add a patient to your consult list, they will show up. So I can easily just pull up the CTU Team B list, and all of those patients will be there because they've all been assigned and admitted to CTU Team B. Then there's also the individual handover within each patient's chart. So for certain specialties, you're going to need a more detailed handover. So for instance, if you're doing general internal medicine or you're doing inpatient cardiology, your patients may be more complex to the point where you actually need to have a more detailed handover. And there will be individual handover notes that you can do within each chart. And then there's the provider team handover, which will essentially combine all of those individual handover notes that you had done for each patient and essentially print a handover list with all of those components. And those components are adjustable depending on your either personal needs or the needs of your service. And this essentially is what replaces our SharePoint handover list. And it can be created very similar to that, where you have the patient's name, their date of admission, their active problems. You can include past medical history. You can include sort of dispositions or whatever else you felt is relevant. Next slide. So this is just sort of your patient list. So again, just kind of reminding everyone, you can get basic info on here, and that may be okay for some people in terms of their rounding needs. Next slide. Or you may need to have a more detailed handover in terms of adding individual patient handover. So this is an example of a demo patient. So for, let's say, Charlie, I actually want to do a more detailed handover. When you are in the chart, on the right side, you will have a handoff section that you can click on, and that will open the sidebar that's in the red bigger box, and you can add. A lot of that information can actually be pulled already, so you can build the template. So for instance, for this, if you want the HPI or past medical history or the active problems, you don't have to type them all in. They're already in the EMR, and you can have them pulled into your handover list. You can create a to-do or on-call to-do list. You can create a disposition section, and a lot of these are modifiable, and you can also collapse some of these if you don't want them to be necessarily visible. So that's sort of doing a more detailed individual handover for each patient. Next slide. The other way to do it is that, let's say you don't necessarily want to open each chart. You are at the end of your either at the end of your week, or you're about to hand over to the next physician, and you just want to quickly go through handover on everyone. You don't need to open every single chart. You can just click handover. Sorry, you can just click write handover that I've highlighted in the red box. Next slide. And that will open again that individual handover, but this time it's not within each individual chart. And you can literally just type your handover, click next and previous, and just go through your list one by one and finish your handover for each patient without necessarily going into individual charts. Next slide. So let's say we have done our handover and now I just want to print a handoff list, or I've just gotten handover from someone, or I'm a resident and I'm starting my on-call shift or my weekend rounding, and you want to print a compiled handover of all of those individual handovers. You can just essentially go to print and then click on handoff, and this will give you a list of all of those combined handovers with that to-do list, with the problem list, with the disposition. And you can adjust what you don't want on the list. So if you do want the code status on there, great. If you do want the problem list, that's great. For some specialties, you may not have a problem list. You may actually just be following them for a single issue and are not interested in having all of that background information. If you're a consult service, disposition may not be relevant for you. And you can add additional things, perhaps in your handover list. If you're an ID service, you actually want a column for, let's say, microbiology results, and that's what you want to pull up in your list. So you can certainly modify and adjust that. Next slide. For some specialties or some individuals, you may decide, well, I don't necessarily want to use a separate handover list. Can't I just combine my patient list, which is going to have all the basic demographics, and I want to use that for my handover? And you can. So this is just an example of a patient list, and sorry, this is a pediatric example, but the principles apply. And you can actually add a to-do on-call list to your patient list. And this way you don't have to do a separate handover. And this column will just be part of your patient list each time when you pull it up. It may be relevant or used by residents that are just coming in to cover overnight and may not be looking for a detailed handover. It may not be relevant if you're a consult service and you necessarily don't have a lot of on-call coverage to-do list. So you can modify it, but certainly the patient list itself can also be used as a handover list with additional notes. Next slide. Okay, I'm going to switch gears a little bit and talk about avoiding pajama time. And what we mean by that is that, so Epic is a fantastic EMR and a great tool for making our clinical workflow and our clinical work a lot more efficient. But just like every other tool, whether it's your phone, social media, your email inbox, if we don't sort of develop healthy habits and set boundaries, the tool that's designed to make our life more efficient can actually contribute to our burnout. We are doing go live in summer, so you want to be doing more of looking at lovely flowers and enjoying nature outside and enjoying the weather, and not be staring at an Epic screen after you get home from work. Next slide. So how do you avoid sort of pajama time and sitting on your EMR and working away at all of your notes and looking at your inbox after hours? And some of these suggestions are not just based on my personal opinion, it's based on some of the informal opinions that other colleagues have given that have already gone through Go Live at other centers. So some of their suggestions are that when people start using Epic, because everyone doesn't have the same level of familiarity, we are doing a big jump from a very basic EMR to Epic. There may be a level of discomfort with doing all of your notes, and there's this temptation to say, well, rounding is very busy. I just want to quickly finish rounding on everyone. And, I'm still learning Epic, and then I'll kind of do my notes at the end of the day. I would really caution against that, because based on the feedback I've had, people then find that, yes, they've been efficient in rounding, but at the end of the day, often after hours at home in the evening, they're then sitting down to do all of their notes, or they're staying later after work to do the notes, and you just don't have the same memory. So I would encourage everyone to incorporate writing your notes as you're rounding, even if it feels a bit rusty at the start, even if it feels that it's taking longer, you will get better and faster at it as time goes on. And there's other ways to make that more efficient. You can use your mobile devices. There will be computers as well as computers on wheels on all the various floors, so you can use that. If for some reason you don't have the same level of comfort at using a mobile device or cannot find a computer, you can also use Nuance Dragon to just quickly dictate your note. So some people don't necessarily like the quick format of the Epic note template. and prefer to have a more narrative note. And you can just dictate into your phone with your Nuance app. And if you've gone to the user lab setting, you will be shown how to set that up. And that note that you're dictating, even without opening a patient chart, will kind of get saved onto your remote desktop. And then afterwards, you can just sit and then sign off on all of your notes or edit or add things as you need to. So definitely don't leave all your note taking till the end of the day. Note bloat is a big issue with a lot of EMRs, and we did have a work group to look at note bloat, and we've come up with some strategies to avoid that. And just a reminder that, you know, as long as the notes are for the purpose of the encounters within hospital, you don't need to necessarily copy all of their blood work or what their chest x-ray shows. Everyone has access to those information. So there's no reason to import all of those things into your note, unless this note is going to be shared with providers outside of Epic. So if it's a discharge note, absolutely. But note bloat is an issue, and one of the strategies we have done is change the progress notes to APSO form. So you're not scrolling through, you know, lots of paragraphs of copied and pasted notes of, you know, subjective and objective section. You're looking at literally just assessment and plan before. And if you need to review the subjective and objective info, you can go down, and you can also collapse those sections. So that way, as we're reviewing notes, it's a little bit more efficient. And then managing your in-basket. And honestly, I think the same principles apply as managing your email inbox. For me, that's certainly a work in progress, but similar principles apply in the sense that your in-basket can become very full, or you don't necessarily want to be spending lots of hours in the evening looking at your in-basket and clearing it. So whatever works, very similar to clearing your email inbox, you can set time aside. Perhaps just, you know, if you're on inpatient service or in clinics, maybe time around noontime is one. You go through your basket, clear out some messages, and maybe just at the end of the day before you leave work to go through messages. Just a reminder in terms of managing in basket, it's very similar to getting all of your paper faxes and things like that. Your admin can have access to it. If you are going away on vacation, and you will be away but need someone to follow that, you can forward your in basket to someone else to make sure that nothing important is getting missed. And then the last thing sort of again is, you know, that can sort of intrude into your evening and pajama time is secure chat messages. Secure chat messages, we have developed policies around that to make sure that, you know, people are not sending messages to do consults. It's really not for urgent stuff. Anything that requires a response within 15 minutes really should be a page, not necessarily a secure chat message. But just a reminder that if you are leaving the hospital, or if you are going on vacation, or if you're not on the weekend, you can sign out of your Epic and sign out of your secure chat. And in fact, you can specify times and say, I am going to be away from this day to that day. So you are not getting secure chat messages when you are not at the hospital and not at work. And that can certainly feel a little bit intrusive. Okay, next slide. I think that was all from me.
Thanks, Anna. The best laid plans, I've got way too much information and we've got way too little time. So I'm actually going to just advance because I want to tell you about a couple of things real quick. The first one is how do you get help? I just will remind you that you know, you saw the LMS access to help and videos and tip sheets and so on. But if you're in system and you hit F1 anytime you're in system, you'll get a contextual based help panel, as you see here. You can then search that for other information, and that will be available to you anytime you're in system simply by hitting the F1 key. And then I'm going to move now really to what's going to happen on June the 4th and what will it look like. And I'll try and wrap this up really quickly. Some of you will have heard about something called cutover. The cutover activities are required for us to be able to move safely from the Meditech system and the paper chart to Epic. And at the end of the day, what does it mean? Every piece of information required to provide clinical care has to be in the Epic system when we flip the switch to go live. So that process is a combination of both automated and manual activities. And you'll see on this slide that this is kind of this triangle where most of the sort of basic information will come across from Meditech, but then on the week leading up to go live, every chart, all 1,350 to 1,400 charts in the organization, will need to be cut over with the help of our registrar clerks, our pharmacists, and our nurses, so that the relevant information is available for you to be able to start caring for your patients. 3 years of Meditech will come over automatically, except for pathology and genetics, which will be 7 years. Solvera goes away and comes in with a new product called Quantum. Don't forget about Clinical Connect, and I would like you to know that we will be the first organization in the province using the new FHIR interface, so that your OLYSS results will also be available in system. Okay, so there will be something called a command center at Go Live. This will be manned 24/7 for a minimum of 3 weeks and longer if necessary. It will be an incredibly complicated process with literally hundreds of people involved at the Go Live Center, which will be down at 293 Wellington. There will be multiple opportunities for physicians to interact with the command center and get the help they need. I wanted to briefly touch on what we call at the elbow support. So there are two kinds of at the elbow supports. We call them provider and non-provider. Non-provider is our nursing, physio, OT, PT colleagues, and provider is physicians, NPs, PAs, and so on. We have gone out to an external expert agency to provide us with 230 at the elbow support for providers that will be distributed across the organization. Every one of these individuals will have done not less than 10 Epic Go Lives prior to arriving to help us. And we have a plan for how they'll be distributed across the organization. We also will have 878 non-provider super users or at the elbow supports for your other colleagues. These are the people that you go to first. And if you can't find one, there are other ways to get help. But I will tell you that it is an extremely robust at the elbow support for Go Live, and we should be able to give you the information that you need when you need it. There will be a call-in opportunity, and the guarantee is that the phone will be answered within 30 seconds. There will be a comprehensive ticketing and registration activity for issues. I will tell you that even if you get a ticketed item that you need to have followed up on, because of the magnitude of the issues in a Go Live operation like this, we can't guarantee it'll get solved in the first day. But if it represents a critical clinical activity or an issue with you being able to sign in and so on, those will be dealt with very hastily. There will be a room at every acute care site where there is an ATE sitting at a computer together with a few other computers, and you'll be able to go quietly and have a conversation with one of these experts if you want to do something off the ward and just need some help or a chance to yell and scream and jump up and down, and the AT can help you. And finally, at the command center, we will be having physician call-in opportunities, probably twice a day, might be once. We haven't quite decided yet, but that will exist every day. And I think Khaled, in terms of opportunities for questions, even though I've got a bunch more stuff, I think we should stop now.
Right. Thank you so much, Barry, Dave, and Amna for this really exciting and important stuff that doesn't come in training and other opportunities. So thank you very much. There are a few questions, but for those who wants to bring in their question in person, please don't hesitate to raise your hand and I'll bring you in to speak your question. So there are a few questions in the chat. There's one from, in the Q&A. There's one from Dr. Carnot asking about other EMRs.
Yeah, so this is a common one. There's lots of folks who have Accuro and several other EMRs. HHS is not in a position to support those individuals' use of an EMR, external EMR. So Greg, you're going to have to decide how you want to do this and to work in both systems, or if you eventually want to transition entirely into the Epic world. If you're coming to an HHS clinic, you must document in Epic, and there will be a way, if you decide to keep your Accuro, that you can send those notes that you create in Epic over to your office, and you can then decide whether you want to upload them also into your own EMR.
Yeah, Ted, go ahead. Dr. Workington, you can unmute yourself.
Yeah, hi. I have a question. Is I'm doing a research project where I'm accessing Meditech data back over 20 years. And so my question is, only 3 years are going into Epic. So does my research project end, or is there a way I'll still be able to log into Meditech like I'm doing now and going back for years and years and years on patients? And in particular in hematology, longitudinal lab data is really, really important. Like, do MCVs go down over the years, indicating, inflammation or iron deficiency, et cetera? So I'm worried about losing, 20 years of Meditech lab data.
Yeah, so Ted, we're not going to kill Meditech. It will be available in read-only access for quite some time, probably a couple of years, because HHS provides support to a couple of small external hospitals who will be staying in the Meditech world. So we're aware of this. It's come up before, and you will have access to that. Don't forget, though, that Clinical Connect keeps lab results many years back. It's not quite as convenient to track, things like, as you say, MCV or platelets or what have you. And we'll bring in probably 3 years. We're just trying to decide of historical OLYSSEY data for those of your patients who go to private labs.
Thank you, Barry. There's a question from Kelvin about when can we log into Haiku and Canto, and can we access the playground through these mobile apps?
Yeah, so let me deal with the playground. Once you complete your UPA, and then you will be able to get access to the playground. So the UPA is the quiz that you get after your main in-class training. Once you've done that, you will have access to the playground. If you are struggling with that, I would encourage you to just wait till you go to your user setting lab, and they'll make sure that you can get into playground. That is a tremendous opportunity to get comfy in the system. And it's also a tremendous opportunity for groups to start thinking about how they want to handle things like handoff and so on, so that they're ready to go for go live. In terms of Haiku Canto, we are having some struggles with getting people into Haiku. Largely seems to be those who have already got McMaster multi-factor authentication. So we're working through that. We're expecting that you'll get in at your user settings lab, but if not, we'll have a process to help you get that established, and you will be able to play with your Haiku as well.
Thank you. There was mention about the voice dictation, and could it be used outside Epic, like for you're working on Citrix on your emails, documents, otherwise?
Yeah, actually, Michelle has just corrected me. Michelle, I didn't realize Michelle was on. Thank you, Michelle. Is saying no to playground for Haiku Canto. I apologize for that. You'll have to wait until after go live. Sorry. So in terms of voice,
using the voice dictation profile, but not only for Epic, but other softwares in your.
I'm going to have to take that one under advisement. I believe the answer is no. So even if you're, for example, in Outlook in Citrix, I don't believe that it will work, but I will follow up. If somebody wants to fire me an email, I see it's an anonymous. I'll be happy to follow up for them.
Okay, Amir brings in a concern that I think it's a concern of many, as you're aware, is the number of computers. We have not seen enough computers around yet, and we're 23 years, 23 days. I hope we're not 23 years away from the adequate number of computers, but we're 23 days away, and we do not see enough computers on units, consult rooms, and even with the WOWs and stuff.
Yeah, so listen, we're aware of this. We're hearing this more and more in the last few weeks. They have done a detailed review of all of the devices that will be available. I think the number, and Michelle may correct me here. I think the number is 11,000 that have been assigned to the project, and about 9,000 in that kind of range have been deployed. So there's more to come. This relates to issues with supply chain, which all of you will be familiar with. That being said, there is a review of all of the devices that will be coming, and that's available on the hub. And then there is an email address for concerns around devices, which I can't remember the email address. I think it's
devices at HHS or at ODYSSEY. I can't remember, but just to sort of follow up, I did send an email to the devices program, just sort of mapping out areas at Juravinski particularly that I think need more computers, and sort of providing a ratio of providers and patients versus the number of computers. For instance, I think F5 is one of those areas. It used to be an ALC ward, but now it's a full acute medicine ward, and the traffic to that ward is a lot more. Same with sort of the back ER consult room. So I've sent sort of a detailed mapping of some of those mismatch and deficits to I think it's ODYSSEY devices at hhs.ca, but for the Juravinski side, I did send out those. Or if there's issues with devices themselves, and I'll see if I can pull up that email address and put it in the chat.
Yeah, I would just make two more comments on this. The first is, don't forget that even though your nursing colleagues might try to tell you that they own the WOWs, they don't. They're meant to use their WOWs together with their Rover devices, obviously, for their day-to-day care. But you most certainly can take advantage of the WOWs and take them with you as you're round. The second thing is that they're beyond the shadow of a doubt. Our residents are telling us that using Haiku or Cantu is very, very useful as you go about your daily work. So please don't forget about the opportunity to use your mobile devices. This will take time to sort out. There will be great gnashing of teeth and so on as we plan this, but the organization, as you heard me say, did actually arrange for a massive number of new devices, and we'll just have to figure it out. There are a few areas where there's probably too many.
Okay, so we're putting the email that if anyone concerned about devices, to email ODYSSEY devices at HGH. But I think we should wait, and so people don't start emailing this tomorrow, because we still you're expecting more devices on the ground. Barry, am I correct then?
Yeah, a modest number. This is a tough one, and we undoubtedly haven't got it right, and it will take some time and patience to get it right, beyond the shadow of a doubt.
Okay, it's like we have a couple of minutes. Greg wants to bring a question in person. Greg, go ahead.
Sorry, that was a mistake. No answer.
Okay.
Sorry about that.
Fine. Thanks, Greg. Okay, perfect. For outpatient booking, yeah, I mean, this is maybe have been covered already. The outpatient booking going to Meditech versus the overlap period. Do you want to reemphasize that, Barry?
Yeah, sure. So starting this weekend, we're starting a process of cutover of all appointments that currently exist in Meditech. And then we'll be moving into a situation that they call a soft go live. And what that means is that appointments that will be happening before June 4 will continue to be managed in Meditech. So if Dr. Azam has an appointment today or on Tuesday, and then he's rebooked to be seen a week later, that will happen in Meditech. The same time, the booking clerks and admin assistants will have access to Epic, and as they enter appointments for after June 4th, that will be happening directly in Epic. They will also then be bringing over all of the referrals that are outstanding in the system over the cutover weekend for those that we already have line of sight on related to the clinics. And then a process for all of us who are sitting on referrals in our office and how to bring those all over into system. And we'll be training your admin assistants to do this. Most of them have had training, but we're going to be making sure that they've got adequate training, and that's the reason for that admin assistant town hall tomorrow, so that process can start.
Fantastic. Just a comment, for you to work on. Heiko and Cantu did not work in
Yeah.
the lab yesterday. So.
Yeah, we're aware of this. And in fact, we have a meeting scheduled for tomorrow to try and figure out what we can do to make this work better.
All right. Fantastic. It's getting very close. It's getting really, really real. So this is very exciting. It's a bit scary, but it's exciting and setting reasonable expectations. So thank you very much, Amna, Dave, and Barry for the rounds today. It's been very informative, and I'm sure you'll be bombarded with more questions through your emails. Thank you very much, and have a good day, everyone.
Thank you.